All right, we are back live and we set page 266 aside. We'll come back to that when we have a new draft. And once we have that new draft, I'm hoping that we can make a motion and vote on it. So we're going to move to H482. Jen, can you show us what we have?
And Jen Carvey, Office of Legislative Counsel. Yes, so we are looking now at H482, which is an act relating to Green Care Board authority to adjust a hospital reimbursement rates and to appoint a hospital observer. Based on some of your previous conversations, I have started a draft. It is unedited, so I put that up at the top. And still talking about it a little bit with the board. But I did it as a strike all just to be able to show you changes, and because there are changes in both sections. So in section 1 on the reduction or reallocation of reimbursement rates, I have added language in subsection C, saying that in determining whether and to what extent to reduce a hospital's reimbursement rates pursuant to this section, the board shall consider the competing financial obligations of the hospital and of the domestic health insurer. So this was to try to get at the kind of balancing issue you were talking about last week, and also requires the board to provide a hospital with the opportunity to request relief from a rate reduction order pursuant to this section.
Maybe go slower through that because this is the first time we've actually seen it.
Sure. So in the language about the board ordering a reduction in reimbursement rates, keeping the language and just making it section instead of subsection, only to the extent necessary to remediate the threat to the domestic health insurer solvency. That was in the bill that came to you, and then adding in determining whether and to what extent to reduce a hospital's reimbursement rates pursuant to this section, the board shall consider the competing financial obligations of the hospital and of the domestic health insurer. And then the second piece is to specify that the board shall provide a hospital with the opportunity to request relief from a rate reduction order pursuant to this section. That was the language that the board had suggested. So that is it for this particular section, and then just renumbered the prohibition on reducing the rate below 125 days cash on hand. Then in section 2, this was another board suggestion to revise the language about reconciling budget deviations from prior years, and instead restoring this language that had been struck. That's why it's highlighted but not underlined. So in establishing individual hospital budgets, the budgets must, and under existing law and then maintained in this draft, reflect budget performances for prior years, and then adding, and if not already addressed pursuant to subsection H, which is the enforcement section, account for any significant deviation in revenue during the, and then change from previous to most recently completed fiscal year in excess of the budget established for the hospital pursuant to this section, and then taking out methodology language because this was accounting.
Okay. Well done.
This was board suggestion. So
Well done.
get them.
Yeah, that's good.
It's good people there.
And then that is it as far as any changes that I've made. So the sunset on the.
We had a discussion when Nancy Kane finally sent her testimony in regarding the 135 days. Kiki, can you put this draft and Nancy Kane's language up on today's webpage? We don't have this one up on our webpage.
I just sent it to Kiki.
Yeah, okay,
I've been
good. All right.
working on it while you were
All right.
discussing.
So, while we're doing that, Senator Douglas has a proposed amendment, a suggestion to be made. You want to go through that and then we'll come back.
So,
Cool. We have it right here.
okay.
We've got it. We'll come back to the 135-day discussion, the Nancy Kane stuff.
If you want to, it's extremely simple.
It is, but I
Yeah,
think
I'm gonna put it up so we can see it.
And so I'm being less official with this. Like I'm not like making a motion or anything.
Yeah,
Yes,
no,
I had
okay.
Jen draw it up, so you had language to look at with your eyeballs.
Think about.
Think about, because I brought it up before, heard from Owen Foster during my fair board. If memory serves, are more or less ambivalent about the idea, though they would like to see it extended, to not include like Mount Stephanie and, I can't remember the other hospital that was in the Chittenden UBM network. So the way that Jen has it drafted for me is just critical access. But I would be happy to extend it to not a critical access hospital that is part of a hospital network. Which would decount those two hospitals.
Oh, so it would be that it's not a critical access hospital or a member of a hospital network.
Yeah, so it would, what's the other hospital that was in?
Porter.
Yeah,
Mhm.
so
Yeah.
Porter.
Central Vermont.
I don't think.
Well, that's not critical access. Oh. Withdraw that comment. Okay, so what would? Is this the language? I'm trying to think about, right now, we've got certain hospitals that are very much in the red and then other, including critical access. Some that are 5 hospitals very much in the red and others about to close. Senator Cummings.
Given the new language, I mean, I think we got into some of this because when we set up the care board, we told them to cut the cost of healthcare. And we have until the finances of the system are shaky. I think with this new language, we told them to take a balanced approach, to look at the health of our insurer, because if the insurer goes down, everything goes down. But to also look at the health of the hospitals. No one wants to shut down a critical access hospital. They're going to do everything they can to keep them afloat. They might give them higher rates. I want,
Everybody in the mix.
yeah,
Yeah.
and so that they have the ability to do that balance.
Yeah, if we take them out, we're making an assumption that critical access hospitals will never be over the top in their income.
And they might now, but they might all get taken over by a hedge fund.
Yeah. They may be making more income, net revenue.
Well, one of the critical access hospitals, a lot of them are the ones that we're seeing struggle, that are in the red, and they've been in the red for a number of years. And my perspective on it is, if things start changing, if they, get a new CFO or whatnot, and they make the changes like has happened in North Country when Tom came in and really straightened things out. So you see hospitals that have been struggling, but now they're doing better. And then something happens with Blue Cross and they're not careful, or as radar, now they're went back down again.
Well, let's remember the language that would cause for all of this to happen. Jen, can you remind us what is in the bill that would put critical access hospitals right there? They'd have
To either have more than 135 days cash on hand and have had a positive operating margin in the previous fiscal year, or be a member of a hospital network that at the consolidated network level has more than 135 days cash on hand, or had a positive operating margin in the previous year, for both.
and
then there's a floor where they can't go below 125 days cash on hand.
We can't be the trusted Green Mountain Care Board to do the job we give them, or we get rid of them. All of our they need to be able to make that balance. The minute we exclude something, if your hospital, maybe, if they do a really good job and they are significantly in the black and they've got 300 days of cash on hand, maybe they should contribute to keeping the hospital afloat, or the insurance company afloat, if they're able, because And the same, somebody else will contribute to keep your hospital afloat because they are critical access. I don't think anyone wants to punish anyone for being well managed. We want to get everyone to be well managed. But I mean, I could start trying to exclude Central Vermont and or
Part of the
anyone.
network.
I know it's part of the network, but they're closing several services in, one of my neighborhood health centers. Yeah. I think everybody needs to play by the same rules.
Can I just echo what Senator Fleming said? I was gonna say about 90% of what she just said, so I agree.
Well, you can say 10% more.
No, but she said 10%. I wasn't gonna say, but 90%.
No, I think at this stage of the game, it's really difficult to take any organization out. Remembering also that right now hospitals are, and as we heard, in our joint meeting with House Healthcare, they're in a transition, and you referenced, Tom Frank coming in and doing all that good work. I think we have to put some trust in the regulatory entity. This will make us the regulatory entity by doing this. But we've already made a decision. They don't need to be regulated in this way.
We already are the regulatory agency, it's legislature.
Well, but we want to keep, we write policy that is kind of the umbrella policy and allow for the board to look at each individual hospital and what should or should not be invoked. And then so let's go through, Jen, can we go through the bill as we currently have it? Well, we can't go through Nancy King's testimony because she is both.
On reduction or reallocation of reimbursement rates and risks to health insurer solvency. They're adopted definitions of hospital and hospital network. You must go through the hospital network definitions. It's the same one we've been looking at. Subsection B, if the Green Mountain Care Board determines after consultation with the Commissioner of Financial Regulation that a domestic health insurer faces an acute and immediate threat to its solvency because its risk-based capital level has triggered a regulatory action level event pursuant to APSA 8304, the board may order a reduction of the insurer's reimbursement rates to one or more Vermont hospitals as set forth in subsection C of this section until such time as the amount of the insurer's risk-based capital exceeds the company action level risk-based capital threshold defined in APSA 8301. So it goes up. Subsection C, the board shall only order a reduction in the reimbursement rates to a hospital that meets one or both of the following criteria. The hospital has more than 135 days cash on hand and had a positive operating margin in the previous fiscal year, or the hospital is a member of a hospital network that at the consolidated network level has more than 135 days cash on hand, or had a positive operating margin in the previous fiscal year, or both.
When we said the board, did we say shall? It said it shall only. Paragraph before, did we say may or
Yes,
shall? May. So they don't, that doesn't mean every hospital with 135 days, we're not telling them they shall. They
No, it's
may.
its authority.
Yes, they may look at all of this. Right.
All right, the board shall order a reduction in reimbursement rates to a hospital pursuant to this section, only to the extent necessary to remediate the threat to the domestic health insurer's solvency. And I've added in determining whether and to what extent to reduce a hospital's reimbursement rate pursuant to this section, the board shall consider the competing financial obligations of the hospital and of the domestic health insurer. And I will just add the continuing conversations with the board about whether to put in some specific language in here about this not being a contested case, but including appeal rights.
Some due process language. That was one of the comments. Yeah.
Sorry,
some due process language.
Well, there is this, I mean, this is providing
Yeah.
due process. That's the opportunity to request relief from a rate reduction, but due process doesn't automatically mean a contested case. There are lots of ways of providing due process that are not specifically the Administrative Procedures Act contested case. So the board can tell you more about their concerns with that. We've been addressing the same issue on S63 upstairs. We'll be
Yes.
coming back to you with not a contested case language. The way I've taken to describing it is, you're entitled to due process. You're not necessarily entitled to the process you would choose. The board shall provide a hospital with the opportunity to request relief from a rate reduction order pursuant to this section. Again, that's where there is additional process afforded. And then in no event shall a reduction ordered by the board pursuant to this section result in a decrease to hospitals or hospital networks projected days cash on hand below 125 days. I pause at the end of this section.
And I think it is helpful to go back and look at Nancy.
Budgets established by the board shall, and changing the language to say reflect budget performances for prior years and not already addressed pursuant to subsection H of this section, account for any significant deviation in revenue during the most recently completed fiscal year in excess of the budget established for the hospital pursuant to this section.
That's important.
It also gives the board in new subdivision F2 the authority on its own initiative, so not just if a hospital comes to it and asks for a budget adjustment but the board on its own initiative may adjust the commercial health insurance reimbursement rates payable to a hospital at any time during the hospital's fiscal year in order to ensure that the hospital operates within the budget established under this section.
Okay, question here. Is this only with regard to the previous section of the bill? But it is overall.
This is overall, this is allowing the board to adjust rates during the year to keep the hospital within its budget.
And so it could be an increase in reimbursement,
It's an adjust, it's not a decrease.
right? Could be either or, yeah, got it. I want people to just,
Right. It's not, it says adjust, it does not say decrease or increase. Then in subsection G, this would give a new subdivision to A. This is the observer language, allowing the board upon finding that a hospital has made a material misrepresentation in information or documents provided to the board, or that a hospital is materially non-compliant with the budget established by the board pursuant to this section. There were additional changes. Appoint an independent observer with respect to any matter related to the board's review or enforcement under the section if the board believes that doing so is in public interest. At the direction of the board, the independent observer may monitor the hospital's operations, obtain information from the hospital, and report findings and recommendations to the board.
so are there any requirements for who this independent observer is? I mean, it obviously needs to be someone who understands hospitals, understands providers, and understands payers. So we don't have any language in here that defines who this person is
We do not.
or
Appointed by the board.
eliminates any conflict of interest that the person might have.
Oh, they have to be independent. So I think that,
Independent,
that
okay,
suggests
but
not a
what,
conflict.
I'm just wondering if we want to put anything in here about knowledgeable about payers, providers, and hospitals, or experience with. I mean, the current observer is someone who has quite a bit of experience. What are the consequences of not having that kind of qualification?
I mean, it puts it in the discretion of the board to identify who the board thinks is appropriate.
Well, I don't want to micromanage the board, but I certainly don't want to leave it open to someone who is managing Walmart. Sorry. think about that. That's looking at nitty. So, we want to say anything about qualifications of the. I don't think it hurts to say something.
Say something like with relevant expertise or something.
Sure,
At least.
yeah. Do we want to say anything about conflict of interest, or is that something that is understood? Independent
Already
there with knowledgeable, okay, yeah.
These. To look at the link a little bit, because once we get two widths in there, who has, well, it still seems like it's.
Yeah, I mean, you want someone who can provide financial oversight and understands how to look at spreadsheets, counting.
I think we're all hoping
Us,
I think we're all hoping that this never has to happen.
we
again.
want it to never happen again.
That's right.
Okay, so then we have an independent observer appointed pursuant to the subdivision 2 shall have the right to receive copies of all materials related to the board's review under this section. And the hospital shall provide any information requested by the independent observer, including any information regarding the hospital's participation in a hospital network. The independent observer shall share information provided by the hospital with the board and with the Office of the Healthcare Advocate in accordance with subdivision D3 of this section, which has the confidentiality provisions, but shall not otherwise disclose any confidential or proprietary information that the independent observer obtained from the hospital.
Question here, I know the board in its order has a limited time for the observer, it's what, 16 months, I believe. It's in the order. Is there anything in the policy here that suggests a limited time for the observer within the order? And do we want to put anything in there about it?
You know, you may have a hospital that is about to go belly up. And you may want to have an independent observer in there until they're solvent. I mean, the minute
Now, if we put a prescription in, we become the regulator and we don't know what the potential
what we're regulating.
is. Yeah, okay. All right, well, we'll leave that one, but I think it's important just to consider at some point. Just leave it.
And then finally, the board may order a hospital to pay for all or a portion of the costs of an independent observer appointed for the hospital pursuant to this subdivision 2.
Then there's another question that Senator Gulick and I were talking about, and is there any limitation to that pay for the independent observer? How much do we want to pay them?
No, but the board is regulating the hospital's budget, so they're going to be looking at.
They all have our phone numbers.
You mean if they're only getting $20,000 for 5 years of work, they're gonna complain? Yeah.
Somebody will call us. I think, you know, if you're paying them 200,000 for two
The hospital
hours of work, I think we'll also get a
Yeah,
phone call.
okay, all right, well, leave that one. Okay, well, you're reassuring me, Senator.
Section 3 sunsets the authority to appoint an independent hospital observer on January 1st, 2030, and the act will take effect on passage.
2030, we'll give it, 4.5
4.5
years. I know the hospitals would like to have it, repealed next year.
I was thinking 10 years. I mean, 3 years, it's like we could just hunker down and get through this. And then after the next budget cycle, we can go back and do what we've been doing.
That's not happening.
Yeah, I think you need to have it be a threat long enough to encourage a change in corporate culture, which doesn't happen overnight.
Well, we also know that there's a lot of work going on for an action plan on hospital transformation. So
Yeah.
let's hold it. Let's hold it at 2030. Could be soon. Okay.
I wouldn't want it sooner. I think that's a good.
No, I'm
Okay.
not sure.
All right. Just have to explore every
Looking for an option.
So Jen, well, there's just one additional thing we put in there, two-ish. Is there,
Yes, I'm just putting in a separate sentence saying student observer shall be an unsafe person, so that way it could be a firm or an individual. With experience and expertise relevant.
okay, my suggestion, unless there are other comments around the table, how do we feel about this bill right now? Going ahead,
I feel good.
Sam, your comment, your inclusion, wanting to include or exclude critical access hospitals. So if you do one more shot
Right now or tomorrow?
right now.
Right now, I really think we should maybe talk about trusting regulators. I think we should also talk about trusting the hospitals. I think that even if every single hospital in the state would have a reduced reimbursement rate right now, I don't think that's going to solve the insolvency problem. Blue Cross Blue Shield, I think it might help. It's just, but I don't think it's going to solve the problem itself. It might stand at the top. But I think it will do that at the expense of hospitals, and especially in critical access hospitals. We just can't do that. I see situations where a hospital is not doing that well, and they turn things around for 1 year, and Green Mountain Care Board says, oh, there's a crisis. If we want all the hospitals that meet this criteria, which includes the critical access hospitals that just barely got it feeder, and then the reimbursement rates get lowered, and then suddenly they're back in the red again.
Well, I would think that the board is not going to want to put a hospital in the red. They've been working now for 5 or 6 or 7 years along with us on trying to have financial sustainability. So you just,
Well, I'd like to think
yeah,
that too,
yeah.
but I don't think guardrails are.
well, this is more than a guardrail. I mean, this actually takes them out. And if you have a critical access hospital that gets bought by Senator Cummings' hedge fund, and they are really over the top in terms of everything.
I'm making $750,000 a year.
Ooh, it's cool.
Manage my insurance.
All right, you are,
I am. With Benny's.
okay. So, committee straw vote on Senator Douglas's proposal here. Who would like to include this, critical access hospital exclusion? Raise your hand if you want it.
Me, yeah, my God.
House can't.
I'm gonna say, all of those who would not, support this proposal, raise your hand. So, okay, yeah, so that, and so, that's it for that. And that is it going forward for that. All right.
Like the motion.
No.
No, we're not ready. Thank you. Thank you, Jen.
Sorry.
Sorry, Jen.
You could move to do whatever Jen finishes. You should look at language.
All right, so Jen, we're at a stage right now where I think we need to let you get your work done.
Yeah.
We're gonna go.
So you have this on for tomorrow, I believe.
They do.
Yes.
Good. And do we have anything we can come back to in 5 minutes, or is that something we need to come back to
Thought you
tomorrow?
had this on for tomorrow, no?
266? We could come back to tomorrow as well.
Yeah, I think I've already done.
Okay.
Yes, let's come back to them. I just wanna
Yeah,
make sure
I
I'm.
want to make sure we have
Everything
everything
is-
straightened away and,
Yep,
yeah, we can come back to those tomorrow, before we adjourn for the day. Because we're spending most of the time on H91. And just so everybody knows who is out there in the real world, we love our critical access hospitals. We really don't want to see UVM, Porter, or Central Vermont Hospital fail in the state of Vermont. But we cannot allow for our a payer to Blue Cross Blue Shield to fail. And it's kind of a working relationship for all of the hospitals and all the payers and all the providers who are dependent on that. So we're trying to make progresses with that. So we are going to go offline. I think unless we're coming back, Jen, with anything before you leave, I want to talk process with you a little bit after we go offline, which is
I
legal.
mean, I can probably, if you wanna vote out 266, I can
Let's take a
try
break.
to,
When?
I can try to finish that.
Let's take